Hello. Hello. Shall I start?
Yes, sir.
Yeah. Good evening, everybody. Am I audible?
Yes, sir.
Yeah. Good evening, everybody. I am Dr. Biswajit Sahu. I am the Secretary of Odisha Orthopedic Association. On behalf of Odisha Orthopedic Association, I am welcoming you all to this academic event, the webinar which is conducted by Odisha Arthroplasty Association. It is the series number 3. The theme today is the deformity correction made easy in total knee replacement. We have a galaxy of eminent faculties today for this academic event. I now request our President of Odisha Arthroplasty Association, my teacher Dr. Tanmay Mahanti, to introduce the faculties and to start the proceedings. Hand over to you, Tanmay sir.
It's good evening, all of you. Good evening, delegates. And it's a pleasure for me to announce the speakers who have come here and to just say that we are having the third seminar, which is the deformity correction made easy in total knee replacement. And for that, we have got two moderators, who are Dr. Atanu Mahanti, who is the Associate Professor of Orthopedics at ASKLEPIT Medical College. He is also a plastic surgery surgeon. And Dr. Vishnu Prasad Patra from AIMS Bhubaneswar. And Dr. Patra, as you know, is a very good academician and he can moderate it very well. And this is a subject where we have got eminent speakers from Odisha, from India, and also we have a guest speaker from Germany itself. Now, if you talk about the people who have come from outside, we look at Dr. Pradeep Mathis Punus. Last time he came, he had discussed a lot of things about him, and he is a person who is known to us in Odisha because several times he has been here. We expected him in the real conference, but now we are doing in a virtual conference. He did his MBBS, Diploma in Orthopedics and MS. He did his MS from Christian Medical College, Vellore in 1995. And though I consider him as a very young surgeon, he has a lot of experience. He is very much interested in upper limb surgery, but he has got some experience in Australia itself with arthroscopy, and he has got arthroplasty interest there, and he has done a lot of fellowships. One of them includes in Australia. We will be discussing about a lot of things about TKA, and obviously we know Pradeep can do it very well because he understands what is done in Odisha itself. Now our second speaker, this time new to us, and is a very man who is always smiling. He is from Ganga Hospital, Coimbatore. Dr. Dhanasekar Raja. He is also a very young man, but he is working in Ganga Hospital since 2002. He has also done fellowships in Australia, Sydney, and he did his diploma in tissue banking. It is an interesting thing because he has done this experience from Singapore itself. In the National University of Singapore, he did a diploma in tissue banking, which is the real thing what we need nowadays. At least the orthopedic surgeons get advantage if you have got a very good tissue bank. As you know, they have got a very good bone bank in Ganga Hospital. So now we are also having him here for discussing about the knees and total knee replacement and other things. And to have the list, I consider, because he is a man from outside the country, we must really look at him, Dr. Heiko Getchen. He is the director of ASKLEPIT Orthopedic Center in Lindenloh in Germany. And you know, he specializes in unique compartmental knee replacements, and he has interest in total knee replacement, of course, revisions, all those. But he has done a lot of research on the cartilage and arthrosis, and he has a lot of interest in 3D joint kinematics. He is a member of the editorial board of clinical biomechanics, and he has more than nearly 350 publications to his interest. I do not want to take much time because we have to listen to these great people who will be discussing about it. I'm hopeful that a lot of things can be done for Odisha. And when people in Odisha we started the joint replacement maybe about 20 years back, now we are mostly going for getting revisions. So this is a time we have to get ourselves always in this type of discussion so that we have our more experience from here, what is done in India, what is done abroad. So I don't want to waste more time. I have to give it to the moderators, Dr. Ratnanumanthi and Dr. Vishnu Patra, to take on this. Thank you.
Hello. Yes, good evening. I think is Dr. Pradeep on board?
I'm here. I'm on board.
Yes,
Thank you.
Yes, yes. So let us go to the first step, the conversion of CR to PS, when and why. Dr. Pradeep, please. First,
Right.
let us now know whether you are a CR surgeon or a PS surgeon.
Right. Okay. I do both. I have no hesitation in changing to PS, or routinely I normally do the CR.
Okay.
Okay. So but I have no hesitation in changing to PS. So I'll discuss some of these things. Thank you for inviting me again for this Orissa arthroplasty meeting. I mean, it's always a pleasure to come over to Orissa, and I mean, even if it's virtual. Right, now I've put this topic down as dished insert. So it's slightly different from what was put in. That was, when do you change over to PS? And I'll try and explain why I have chosen this particular topic. Okay, I may be simplifying a few things, but nevertheless, the principles are what I would like to sort of explain through this talk. So why was this thing called the dished insert created, right? I mean, this dished insert is what the Smith and Nephew call it. The others call it curved plus or ultra congruent and various other things. What is this dished insert? You all are familiar with the CR knee and the PS knee, and there's always a battle between the two sides saying that this is better or that is better. But I'm not going to get into that right now, okay? So let's look at what we normally do when we look at the knee. Now we have this posterior slope, or all knees have this posterior slope of about 7 degrees on an average. So why is there this posterior slope? Or let's look at it this way. When you do your TKA, suppose you retain your PCL and you cut off your ACL, and when this knee flexes, it is hinging around this PCL. And as it's flexing, what you see is that there is rollback. Okay, there is a rollback of the femur, and you can see that it's rolling backwards. Now, obviously, if you have the native slope, or if you have a slope like that, it can roll back a little bit better. There's less of anterior translation, and it rolls back well. So what will happen, let's say, if you make the slope at 0 degrees with the PCL intact? All of you have seen this. Those of you who are CR surgeons sometimes see this. So what do we do when we have this kind of a situation? Well, all you really need to do is increase the slope. You really don't need to release the PCL. You can increase the slope, and that tibial tray will sit better. So when you're retaining the PCL, you try and retain that native slope so that the rollback can be there. Okay, so let's look at a situation where you cut the PCL. Okay, what happens when you cut the PCL? Now, all of you know that the flexion gap will open up whenever you release the PCL. So now you're in a situation where you need to reduce the flexion space, well, relatively speaking, because you have cut the PCL. So one way to do this is to reduce the tibial slope, because when you reduce the tibial slope, your flexion space is going to come down. Okay, so now in your PS knee, that is when you cut your PCL, you want to reduce the slope, right? That's what I said. Why? Because your flexion gap is increased. What will happen if now you cut the PCL and instead of the 0 degrees, you're going to keep it at 7 degrees? What will happen? You can see that the flexion gap will increase dramatically, and you'll get flexion instability. So that's not good. So you cut the PCL and you put it at 7 degrees, and that's not good at all. So what you really need to do is, when you're going to cut the PCL, you need to reduce your slope. You need to keep it more towards 0 or 3 or something of that sort, but closer towards 0. You don't want to try and reproduce the native slope when you're cutting off the PCL. So that's the principle behind this. Not only that, see, if you have a slope and you try and extend the knee with the post, you can see that all the pressure is going to come onto the anterior part of the post. Let me explain this to you with a few diagrams. See, now you cut the slope, say, at 7 degrees, and you can see that all the pressure is coming from the anterior part on the post out there, and you're going to have this notching in the front. So to avoid this, you can reduce the slope. So when you reduce the slope, you can see that the pressure on the anterior part of the post is a lot less, and you have less notching. So basically what I'm trying to say through all this is that if you're doing a PS knee, you would like to keep the slope more towards a 0 degree, 0 or 3, right? But if you're going to do a CR knee, because the PCL is there, you want to roll back, you like to keep the slope between 5, and 7 degrees. Okay, so this is normal biomechanics, which you would talk about. I know it's simplifying things, but nevertheless, this is basically what it is. Now, you are a CR surgeon. I don't know how many of you are CR surgeons, but anyhow, when you're doing a CR surgeon, you may have increased the slope, or you may have done something and you accidentally cut the PCL. Now what happens? See, you can see that the PCL is cut. Obviously, your flexion gap is going to increase, right? So now let me show this in a diagrammatic way. So you have made your 7-degree slope for your CR knee, but in the process, you have gone ahead and cut the PCL. What will you do if you put your PS insert there? I've already told you you're going to get flexion and stability because you've increased your flexion gap. So now don't tell me you're going to be going ahead, making a cut again. You're going to make it, a 0-degree slope. All that is just next to impossible now that you've already made it into a 7-degree cut because you're a CR surgeon. So this is where this concept of this dished insert or curved plus insert has come in. You can see there, that's your increased slope in the front. So you're preventing that anterior translation of the femur. So this is the curved plus, and this basically is what you can do if you cut your PCL in a 7-degree slope. So what I've basically said is that you are a CR surgeon and you accidentally cut the PCL. What you need to do, you need to use a dished implant to try and prevent that anterior translation. So now, if that is the situation, you can use a CR knee when you don't cut the PCL. And well, why not you use dished insert instead of the PS for all surgeons? So you do your 7-degree slope. If you cut the PCL, you use your dished. If you don't cut it, you use your CR knee. Because after all, it's CR knee is a bone preserving surgery. Now, why do we use the Corale instead of, say, a solution stem? Because you're always thinking of the revision. You're always trying to preserve bone. So when you look at it that way, there's no doubt that the CR knee is better than PS. Forget the fact that, it may be having less revision rates, etc., which I'm not going to get into. Purely for the sake that it's a more bone preserving surgery, it probably is worth it. So can I go ahead and say that when the PCL is cut, forget the PS post, just use a dished implant? Do you think that's okay? Well, you have clinical studies to say that that is okay. So you got 2 groups. This is a randomized control study, right? One with deep dished and a posterior stabilized where they cut off the PCL. And you can see that the results, ability to climb steps, etc., is all just the same. But if you actually go back and look at almost all biomechanical studies where they have cut the PCL and then they've studied the anterior translation of the femur using either a deep dish or a posterior stabilized, the one with the post, they'll all tell you that the deep dish does not prevent the anterior subluxation of the femur like the post. For example, I've just shown you one study, and this is just a slide showing a graph. If you look at it, this is the curve of the quadriceps, pressures or the forces that are there. If the PCL is cut, now I'm telling you these are all where the PCL is cut and you put in a PS insert. You can see that the forces are much less for a PS knee, for a posterior stabilized knee insert as compared to a CR insert or even a dished insert. Dished insert may be slightly better, but PS is definitely superior when it comes to the quadriceps force when you cut the PCL. All right, this is for PCL deficient knees and you put these kind of inserts. If your PCL is not cut and you put a CR knee, that's probably even lesser pressure than you would get if you do a PCL with a cut PCL. I'm sorry, PS post with a cut PCL. So I would put it this way. If you ask me the question, when the PCL is cut, can the dished implant replace the PS post altogether? Probably not. A dished implant is definitely not as good biomechanically as a PS post when you cut the PCL. But when the PCL is not cut and you got a pretty good cut, should I go ahead and do a PS or CR? I would probably think a CR is better purely for the fact that you retain much more bone. Okay. But there are some situations when even a CR surgeon should think twice about whether you want to use a PS knee, even if your your PCL is intact. For one, it's HTOs. Not all HTOs, but most HTOs. Why do I say that? Now you look at this particular side. Okay, you put your plate, and what you can see is that the slope has increased or is reversed, right? The slope is actually reversed. And here, if you go ahead and do a CR knee where you put your 7-degree slope, you can see almost definitely you'll cut off the PCL. So there's no point going and using a dished insert. Yeah, I'd rather go in for a PS knee, and I'll go straight for a PS knee rather than trying to do 7-degree slope, cut off the PCL and put in a dish. I know I'm going to have problems with my PCL. Let's look at the other one where your slope is actually increased because you put your plate sleeve anteriorly. Here again, your slope may be 10 degrees or 15 degrees instead of the usual 7 degrees. And if you put a 7-degree slope here, you'll find that your whole joint line has gone up, which is also not good. So generally speaking, when I have a HTO case, I would err on the side of using a PS knee. Not always. I mean, if it's 7 degrees, that's fine. But generally speaking, I'll err on the side of using a PS knee. Inflammatory arthritis, especially in patients where you're doubtful about their taking the DMRDs and other drugs, the PCL can become worse. Though there are studies that will tell you that you can do a CR knee even in inflammatory arthritis, but I think very often they do get problems later. And so I would go for a PS knee very often, even though the PCL looks pretty good. Now, severe deformities, I've seen surgeons, I mean, I myself probably do varus knees probably more than 15 degrees, but valgus, personally, I feel balancing is a little more easier with gross deformities. And it's been shown also, I've just shown you some references there where they've shown that even most CR surgeons would change over to PS knees in these kind of situations. So I would be ready with a PS knee and have a very low threshold to change to a PS knee in these kind of situations. So if you are a CR surgeon like me, there are some times when you need to think, look, CR is probably not the best for this particular patient. PS is probably better. At the onset of the surgery, look at the status of the PCL. The PCL status is not good. Don't think of trying to do a CR and replace it with a dished. I would rather go for a PS because a PS post-knee is much better than a dished insert. Similarly, I look at the posterior tibial slope. If it's markedly increased or if it's reverse slope, I'll again think of doing a PS knee, not a dished knee. I mean, you all know that, if you're doing a CR knee and you're in between sizes, you need to go for the smaller size. And if you're, doing a PS knee and you're between sizes, you go for the larger size. Why? That's partly because of your flexion gap problems that you get when you release your PCL. And one of the things that, some surgeons do, they would protect the PCL insertion with the tibia, with osteotome. And others, if you have to recess the PCL, just to adjust your flexion gap again, it would be better to recess it on the tibial side than on the femoral side. These are a few tips for CR surgeons like myself. And you should not be stuck on the fact that you're going to do a CR knee. In between the surgery, before you make your tibial cut, decide whether you're going to do a PS knee and a CR or a CR knee. If you are a CR knee, continue to do so. But if you accidentally weaken or you cut the PCL during the surgery, then you go ahead and use your deep dished or your ultra congruent insert. But if you're a PS surgeon, go ahead. PS is pretty good, but be careful because you always have to think of your revision. All right. So which is why even in smaller size, the other thing is, in a very small osteoporotic femurs, though there is controversy even in this, I personally would prefer a dished where I could, partly because of the fact that I'm very worried about the notch sort of going and cutting the condyles, where in some situations you've had that, especially if you're going to use lateral or medial epicondyle osteotomy. But I would like to leave this slide with you. Okay, so this is a CR knee dislocated. Now, a PS knee is not going to sort this problem out. Insert is not a substitute for good surgery. It's not a substitute for good balancing. A good surgical technique and balancing is far more important than any type of insert that you're doing. And I think that is the most crucial thing that you need to remember. Thank you.
Thank you. Thank you, Dr. Pradeep, for the very nice presentation. So I have got two questions. One is that which is more forgiving for a younger surgeon, CR or PS? What is your opinion?
Yeah, see, I mean, I think it depends on who you're trained with and how you've been trained. And I think training is what is more important than choosing between CR and PS. If you're trained with a surgeon who's taught you how to do CR knees, then do your CR knee. If you're trained with a surgeon who's done PS knees, do your PS knee. Once you've gained expertise in one of those techniques, then you can think about doing one or the other. But I don't think, you should be trained well. That's what I think it is. That's more important.
Okay. My second question is that how do you confirm that your PCL is damaged during surgery? So accidental damage. You are planning to do a CR, but subsequently you feel that your PCL is damaged. How do you know that on the table that yes, my PCL is lost?
Yeah. Sure. I mean, as I said, see, I would sort of start off even before doing the tibial cut. I'll sort of judge to see whether the PCL is intact, whether it's stout, whether it's strong or not. The other thing is, when you make a tibial cut, one of the things I do is I always put the spreader between the femur and the tibia and flexion and put it to stretch and then feel for the PCL. If the PCL is taut and good, then I know that I can rely on this. I mean, some other surgeons also go ahead and inject the sheath of the PCL, but I don't think that is a test for integrity. I think it is a feel also with your forceps. You can see whether it's intact or not. If I have a doubt, I won't hesitate using a dished insert if I'm a CR surgeon.
Okay, thank you.
I don't know whether any of the other faculty or others have any other suggestions or any other opinions on this.
So Pradeep, so there are two things. One is that kinematic conflict. If your slope is less, then you have a kinematic conflict. Or other way around, if you have increased slope, then again you can have a paradoxical rollback. How do you address these things?
I think Gretchen probably will be the best person to answer this. I think he's the biomechanical expert on this. I'll shift that over to Gretchen.
That's very nice from you. Thank you. I think you explained it in your talk. So if you start with 7 degrees of slope and then cut your PCL, which happens if you have such an amount of slope inside in your cut, once in a while you cut some parts of fibers of your PCL because of the slope. Then I think your deep dish definitely is one option. What I also think is that the geometry of the implant and the geometry of the insert matters a lot. So I think you cannot compare single radius knee with that insert with a multi-radius knee like a PFC, and especially when it comes to the attuned knee, the conformity of the insert is so high that you're allowed to do a CR insert even if you have cut the PCL. So I think the geometry of the implant can help you a lot also on that part.
Yep, I mean, the other thing is also like I actually in most of the diagrams, what I've showed you was the Dupuy version of the insert where you have a marked increased anterior lip. But both in the Zimmer as well as in the Smith & Nephew one, it's as Gretchen said, it's more of the congruency of the insert and the femoral implant, which sort of helps with the stability. In those kind of implants, you're a little more forgiving than the PFC.
Okay, thank you very much. Now, may I request Dr. Patra to take over and for the next talk. Dr. Patra, please.
Good evening, all. I have just a couple of questions for Dr. Pradeep. Dr. Pradeep, it's a nice presentation, and really I could know when to shift from CR to CS. But I have just a couple of questions. Like, as you said that when there is anterior lift, you have to decrease the slope. So increase the slope. How you decide how much slope is to decide, whether it is eyeballing or you have some specific measurements?
Yeah, so if I'm doing a CR knee, it is usually eyeballing to the native slope. That's what I would like to do. But, if I feel that the slope is much more, something like 10 degrees, then I wouldn't really go for a CR knee. Because I know in that process, I will cut the PCL. So I'd rather go for something else. So you have your jigs. For example, your jigs have, you can change the slope. If you're going to use a 3-degree jig, you just have to increase the slope a little bit more. And you can eyeball it on the medial side to whatever the native slope is. You try and reproduce a native slope in a CR knee.
Okay, thank you. So one more question, like as you said that because of the PS knee, you have need to cut a lot of femoral condyles. So is there any guideline that particularly in females you go for CR knee and males you go for PS knee, or is there any guidelines, or how you decide which patient we should go for CR or which patient I will go for PS?
Right. Now, as I said, I don't think sex is really an important thing. If it's a very small femur, I would try and stay away from a PS knee, partly because of the fact that I might, I'm worried about the size of the residual condyle. But how do I decide whether I'm going to do a CR and or PS? See, I'm a CR surgeon, so naturally I would do a CR for most knees, except, as I mentioned in my talk, if I feel that the PCL is bad, if I feel the slope is too much or too little, or if these are the main things, or if the deformity is too much. Only in those kind of situations I'll decide straight away, look, I'm not going to do a CR knee, I'm going to do a PS. If during the surgery I accidentally cut my PCL, then I'd go for a distal, if I'm already committed to a 7-degree slope or the native slope.
May I ask one question?
Yes, sir. Please.
Yes.
No, you go ahead. Vishnu, you go ahead. You have some question. Please go ahead.
You complete, sir. I will go after that.
Okay. Dr. Punus, nice to see you again. Just wanted to ask you. Hi. Just wanted to know if you are releasing the PCL, your preference for releasing on the tibia side or the femur side, and how do you do that?
Yeah, no, I prefer doing it on the tibial side because the tibial insertion of the PCL is quite large and it goes down quite a bit. So I personally would release on the tibial side rather than the femoral side.
You go on increments, right?
That's right, in increments. That's right.
So for information of everyone, Dr. C.P. Das is our president of Odisha Orthopedic Association. Welcome, sir. Thank you for joining.
Thank you, Dr. Punus. Thank you.
Gretchen, can I ask the Gretchen what knees he uses, CR or PS?
I'm a CR surgeon, so 85% of my knees are CR knees, and I think the limitations are nicely mentioned. So I think it's very similar to my indications for CR and PS knees.
Okay, just one question to all the panelists. Like if I talk of my state and my city, Bhubaneswar, 90% of patients are being treated by a PS knee, and less than 10% or even less than that is by a CR knee. And all the new beginners, a osteopathic surgeon who want to start the surgery, they usually start with a PS knee. Is it something like that PS is easier than CR, or the complications of CR are more that people are more towards the PS knee? Any just suggestion from any of the panelists, Dr. Graichin or Dr. Pradeep? Or Dr. Chitra sir want to speak?
Okay. I just wanted to tell you that this has been answered by Dr. Punus in the beginning. The people who are trained by CR surgeons, they do more CR. Like, with bigger deformities, CR is not an option. And with standard knees, varus deformity up to 10 to 15 dB, mild flexion deformity, CR is, routine in my practice. I do CR most of the time because I'm trained with people who are CR surgeons. And PS, of course, I do in a bigger deformity. So I think partly it depends on how comfortable you are doing with the CR. CR requires a lot of precision. CR, you have to be very precise when you are doing a CR. But PS, PS is probably much easier to start with. That's my opinion. Dr. Graichin and Dr. Punus maybe would answer.
Yeah, I think the same comment from my side. It's even country-wise different in Europe. So if you go to the UK, I think more than 90% are doing PS. If you go to Germany or Switzerland, more than 90% are doing CR as a favorite implant. So it's training. That's the main factor, I think.
So I do 100% PS because I trained with Ranavat. So that's how it is.
Dr. Graichin, one question. In Europe, is it like people are changing from CR to PS gradually? Because when I was in Belgium, previously they were doing CR knees more, then gradually they have changed to PS knee because of different factors they mentioned. Is it true, or it is like that only?
I don't have. I have not seen any development like you mentioned in the countries I visited over the last years. So I think if you are CR trained, then normally you stay with that. Of course, you should know the limitations of the CR knees, and then you should be able to do a good PS knee. And it's the other way around. So there is no real change in our countries.
Because the shortage of time, we'll go at the next presentation. The next presentation is on epicondylar osteotomy. For me, it is one of the difficult steps during the knee replacement. And today I feel I will learn a lot from Dr. Graichin And I welcome Dr. Graichen to present his talk on epicondyle osteotomy. It is over to you, sir.
Thank you very much. So, share my screen. So the epicondylar osteotomy is one option we use very frequently in the valgus knees, and once in a while also in varus knees. But my talk will mainly be on valgus knees. Maybe later on in the questions we can discuss a bit also on the techniques on varus knees. So the goals, I think, in the valgus knees are the same like in all the other knees, but sometimes they are more difficult to achieve. And so the big question is, why is that? And first of all, I think we have to look at the specific anatomy of the valgus knees. And of course, they have their hypoplasia or their defect on the distal lateral femoral condyle. That's why they are a valgus knee. But a lot of those valgus knees are valgus knees only in extension. When you flex the knee, most of them are balanced. So that's a very interesting fact, and that is also very important later on for your releasing technique. Another factor of the pathology or anatomy of the valgus knee is that you automatically have a lateralized patella, which I address automatically in my lateral parapatellar approach, but that's something we can talk about a little later on. And then you also have to look at the rotation between the femur and the tibia. There's a lot of lateral rollback in the valgus knees, a lot more than, for example, in the varus knees. Then also outside the knee joint, you have some changes not in every valgus knee, but you have to look at those parameters, which can be an increased antetorsion on the femoral neck side or an increased external rotation of the thigh. And then, of course, you have a lot of specific cases, post-traumatic, extra-articular deformities ending in valgus knees, but I think that's a separate issue. So I try to focus a bit on the intra-articular valgus knees. So the take-home message from that slide is analyze your valgus knees. There are a lot of differences between them. And you should know what kind of valgus knee you have there before you start the surgery, and then check it during surgery again. So I show you it with the navigation, and the navigation, the nice thing is that you visualize the pathology. If you look at this middle picture here, and here you see the hypoplasia of your distal lateral condyle. And if you look to the left side, you see that in this knee, there is no hypoplasia of the posterior condyle. So that is almost a normal posterior condyle in that knee. So that is very important because you have different stabilizing factors in your or on your lateral side, and you have to address them separately to get a good result. So Keplish also published on his lateral approach that was in the 80s, so that's 40 years back, but it's still a very good approach, I think, for the valgus knees, because all your releasing steps are on the lateral side, and simultaneously you solve the problem with the patella. And then it's a sequential releasing technique, whether it's 3 or 5 step. I don't think it's very important. I think you have to address all the different structures separately. There is one group that published on a tightening procedure of the MCL. I don't have any experience with that, and I'm not really sure whether this is really possible. So the problem of the lateral side is that a lot of the structures, for example, your popliteus or the LCL, they have also a big effect on the flexion gap. So if you release those two anatomical structures, of course you can get a balance in extension, but then you're unbalanced in flexion. And the only two structures that affect only in extension is the ITB and the posterior capsule. So those are the two structures we should address. The others, I think we should not touch. And if you release those two structures once in a while, that's not enough. And then some Frenchmen developed this technique of the sliding osteotomy of the lateral condyle. So by shifting your lateral condyle distally, you just address the extension gap. There is no effect for the flexion gap. So that's the technique for those valgus knees that are balanced in flexion and are only imbalanced in extension. And if you have done your release of the ITB and the posterior capsule, and there's still a mismatch in the extension gap, then it's the indication for the sliding osteotomy. So they have done it also with the lateral approach. And to determine the sliding distance, they use the spacer blocks, what you can do with the conventional technique, and then you fix your piece of bone with screws. We did the same without the navigation, and for us it was a bit difficult to fix that piece of bone in extension, because that's the position where you should fix it in that conventional technique with the spacer inside. And the other problem we had, that we were not able to determine the sliding distance before the osteotomy. And once in a while, in this very small knees, the sliding distance is higher than the distance between the insertion of your lateral collateral ligament or the popliteus, and then you slide it, but you cut the insertions. So that's not a good indication for that osteotomy, and you should know that before you do the osteotomy, we believe. That's why we introduced the navigation in that technique. The other nice thing is that you see the problem. So here on the left side, that's the graph showing that it's a valgus knee. So you see that's around this 10 degrees of valgus, but you also see it's a valgus knee only in extension, maybe up to 50, 60 degrees of flexion. Above that flexion degrees, it's not a valgus anymore. So if you then look to the right side here, those are the graphs between the medial and the lateral gaps. And you have very parallel graphs above 60 degrees of flexion. So that's a balanced knee in flexion. There's an unbalance here between 10 degrees of flexion and 50 degrees of flexion. And that's the area your releasing technique should address. So that means you do your release of the ITB and you do your release of the posterior capsule, take out the osteophytes and all that. And if that is enough, then fine, then you will have parallel dots between here. If this is not enough, then that's the indication for the sliding osteotomy. So how to calculate the sliding distance? You can do it with your spacer blocks if you do it conventionally, and you can also do it with the navigation, then it's a bit easier. So you have a difference between the medial and the lateral gap under stress, and that difference is then multiplied by 2. So that's based on experience. Multiplied by 1 was not enough, and multiplied by 3 was too much. So that's why we ended with this number 2. This is the way you perform your sliding osteotomy. It's a parallel cut to your lateral cortex of the femur. And of course, you should not cut into your lateral cortex. But don't make that piece of bone too thin. So that's around 1 centimeter here in this area. Okay, that's the nice thing with the CR knee. You have already made your fixation holes, so you know you don't want to penetrate with your cut here. And then you just shift it distally. Okay, you don't want to shift it posteriorly, just distally. After you have shifted it by this around 8 to 12 millimeters, then you fix it with 2 cannulated screws. And again, you see here, there is no change for your posterior cut. That is the same. It's just shifted distally. And after you have fixed it, you remove the overhang of the bone, and then you can place the implant onto, so the trial implant first of all, onto this bone. And then again, you make your stress test and look at your axis. That is the one here. So now you're in between 0 and 1 degree of valgus. So that is corrected. And now you look at the graphs of your gaps, and you see now it's parallel or almost identical between the medial and the lateral gap throughout the entire range of motion, starting from 0 to 100, whatever, 30 degrees of flexion. So that is a balanced knee now. Does it work? So we have published 2 papers on it. The first one in 2013 was more on the technique in KSSTA. And the other one was on the midterm results in the knee 2 years back. So in that publication, we reported on almost 100 cases. The follow-up was almost 5 years. We had 3 complications. So 1 dislocated epicondyle out of 100 cases. That's not a lot, but that learned us a lesson. So that was a patient with very soft bone, a rheumatoid patient, and we made the bone cut a bit too thin. So don't hesitate to make it a bit bigger instead of make it too thin. The other thing in the lateral capsule once in a while is very soft, and then in that time we interpositioned the fat pad into this lateral capsule to close that. Nowadays we separate the 2 layers, the synovia and the capsule, from each other, and then we interposition the synovia to the capsule. The sliding distance is around this 1 centimeter. And then the alignment with that is very nice. And what is more important than the alignment is that you also have good balance there. Of course, the scores are significantly increased, and that I think is the important message, that we don't have any instability. We always use a mobile bearing in the valgus knees because of their enormous rollback on the lateral side, and we never had a problem like spin out or something like that. So to summarize the sliding osteotomy, I think it's a very reproducible and safe technique. Of course, it adds an additional time to the surgery. In the beginning, I think it's 10 minutes. Now for us, it's around 5 minutes. There are no changes in the post-op protocol. So full weight bearing, full flexion, everything like in a normal knee is allowed. Your patients get very good early, and they stay good for the mid and also for the long-term results now. The limitations of the technique you should know. If your MCL is not intact, of course, that's nothing you can solve with the sliding osteotomy. That's something for a hinge. If the sliding distance is larger than the distance to the insertion of the popliteus or the LCL, you cannot perform a sliding osteotomy. Again, you need more constraint. And the bone quality must be sufficient. So if it's a very soft bone, then we had the problem with the dislocation. So that is one case where you see that here you see the 2 screws, and here you see the slided piece of bone. That's the lateral view. Again, the 2 screws. So it's a bit easier with the CR knee, but we also have done it now in quite a number of PS knees. And here again, you see nicely the hypoplasia of the distal condyle, but the posterior condyles, they look both very normal. Of course, not every valgus knees gets an osteotomy, and so I just want to talk very briefly on the other options. So once in a while, we do unis on the lateral side, and I show you one case of that. I think if you have an isolated lateral arthritis, and not a fixed deformity, then it's a good indication for a uni. Of course, the majority are total knees, and I think a severe valgus deformity is still an indication for a hinge, especially in the older patients. That's a very straightforward procedure. So in those cases, we go for hinges. So this is one example for a lateral uni. You see the valgus, you see the medial compartment looks good. The patellofemoral compartment also looked good. She only had isolated problems on the lateral side. That was a correctable valgus. So we had gone for a lateral uni. I think for the lateral unis, the fixed bearing is the better option. There's no problem of spin out. And you also have to remember that the natural slope of your lateral compartment is less compared to the medial one. So once in a while, you only have maybe 1 or 2 degrees of slope. And again, you copy the slope. Don't put more slope than the natural slope in a uni. Okay. And that's the opposite. That's the old female patient with a fixed valgus with a lot of comorbidities. We want to have it straightforward surgery. So I don't think it's a good candidate to go for an osteotomy and all that stuff. So then it's a straightforward hinge, cemented. That's 35 minutes. And there is not a high potential for any complications. So for my valgus knees, I think, look at your valgus knees. They are not all the same. You have fixed, you have non-fixed valgus knees. You have valgus knees that they have their hypoplasia only on the distal part. Some others have it distally and posteriorly. And then, of course, you have intra and extra-articular valgus deformities. But also analyze the patient. So it's not all around the knee, it's also all around the patient. So age is important, bone quality is important, comorbidities are important. And then the surgical technique must address the ligamentous status of the knee and use the optimal implant for that, starting from unis up to rotating hinges, but also from the technical side, from the soft tissue releases up to the sliding osteotomies. So a valgus knee is a more difficult knee, and as we do it only maybe in 10% of the cases, it is even more difficult for us. Thank you for your attention.
Thank you, Dr. Graichen. It was a nice presentation, and I really got something more about the lateral epicondyle osteotomy. Just for everybody, I have some couple of questions for you. Like you said, minimum thickness. What should the minimum thickness of the lateral epicondyle should be kept?
So I try to keep it at your distal part of the femur around this 1 centimeter. Of course, then in the anterior part, it gets a little thinner, but in this distal part, it should be around this 1 centimeter, maybe 8 millimeters, but that's the minimum.
Okay. Next thing is, what is your threshold that at this point of time, I will go for epicondyle osteotomy and not go for further soft tissue release? What is the mismatch between the medial space and the lateral space, the difference, so that you think of going for a osteotomy rather than a soft tissue release?
It is, so I think the minimum difference to go for something like an epicondylar osteotomy, so in all my valgus knee, I do is my release of the iliotibial band first, my posterior capsule first, osteophytes out. And if then in the extension gap, a difference is between 4 millimeters and 1 centimeter, then I would go for the osteotomy. And if it's more than that, which would show something like a torn out MCL, which I cannot really balance against, then I would go for the hinge.
Okay, thank you. And now I just need some opinion from the other panelists, like how often they need this epicondylar osteotomy. Dr. Raja and the local faculties, anybody can just.
So,
How often you need?
So probably for all our valgus knees, we do a valgus stress, valgus varus stress test. And any surgical deformity more than 10 degrees might land up in lateral epicondylar osteotomy. Something like more than 10 degrees, 10 to 15 degrees, we need to do a osteotomy. So with this technique, we have reduced the extent of use of constrained processes. So very good work from Dr. Gretchen. A lot of cases he has reported with good long-term follow-up. So now more often I'm using this technique. I use a PS processes, but in spite of that, we are able to do a osteotomy, slide it down, and get a correction without the need to use a constraint process. Our need for constraint process is totally come down with this technique. Very good technique. And sometimes if there is flexion tightness as well, we can correct it by sliding it slightly posterior and then fixing it. So that also can be done. It's a very useful technique.
Dr. Sipidas, sir, can I know your opinion? Right? How often you go for this osteotomy?
I think Dr. Das is muted.
Sipidas,
I think he has left.
Dr. Padhi, can you please tell, in your experience, at what point of time you really go for epicondylar osteotomy?
As it has been discussed, usually when a normal, say 10-20 degree of valgus is there, usually it is achieved by a posterolateral capsular release only. So that corrects the extension gap, and that is enough for a small amount of valgus, and some amount of the IT band also can be released. Epicondylar osteotomy is reserved for those which have more than 20-30 degree of valgus, and it is a fixed valgus, not correctable. So those are the cases where you need more of a epicondylar osteotomy. When it is a fixed valve, you do, as Dr. Raja was telling, you do always a stress test. You do a stress test, how much it is correctable. If it is not correcting beyond 20 degree, 30 degree of valgus, then you must make up mind that at any point of the correction, you will need a epicondylar osteotomy. I think Dr. Gretchen can also add to this.
So does it interfere with the union of the osteotomy? Has anybody
that is the question which I wanted to ask Gretchen. Many people they don't fix it, so they only do a sliding osteotomy without fixing it. What is your opinion on this? The lateral side, for the lateral side.
I heard about that, but I only heard about that in India. So I think in the rest of the world, we try to fix that. We are not very confident to leave that piece of bone unfixed. Maybe it heals to the bone, but maybe not. And I don't think it's a very big problem to fix that piece of bone with 2 screws. It's very straightforward. It gives you more stability and safeness, and also the post-op rehabilitation protocol is also, I think, a lot easier with the fixed epicondylar.
So maybe because of osteoporosis, this fixation usually is not so good, and the sliding part of the bone may break while fixing. So maybe because of this, people avoid doing it. What is Pradeep? What is your opinion, Pradeep? For
I also agree that I think it's better to fix it, because the whole purpose of this is to give it stability. So if you have something that's not fixed, you really do not have the stability on the lateral side. The other thing is, especially for PS surgeons, you have to be quite careful about this osteotomy, because when you have small femurs and you're going to do your sliding osteotomy in a PS knee, I've seen several X-rays where you've had a fracture of the condyle through the notch as a result of this osteotomy. So if you have a small femur and you think that you may require it, be careful about using your PS knee. Raja, what do you do when you have a small femur with where you have a valgus? I know this is a rare situation and it's not something that you always commonly see, but when you do, what are your steps to get out of it?
So if you have a small femur and the lateral condyle is nicely sclerosed because of the valgus deformity due to secondary arthritis, there is no harm. You can still slide down. We have a sclerosed bone is always good enough to get a fixation. But if it's very osteoporotic, like the case Gretchen described, where one of the cases failed, I wouldn't do the osteotomy. I'll do use something like a constraint processes. where there is a lot of osteoporosis and a small P.
I think that's something that we all need to remember, that lateral condyle osteotomy has its limitations.
One more thing we have discussed about the lateral side. Sometimes on the medial side, Gretchen for you, on the medial side, what happens when you have done a lot of soft tissue release, even after that fixed varus deformity, we usually end up with some amount of lateral opening up. Even if you have done a good soft tissue release, the lateralization of the tibial, but whatever we have done, and then we see that even then we have a little opening up on the lateral side, and it has been recommended for doing a epicondylar osteotomy on the medial side. So any experience on that?
Yes, I've done it on the medial side, but that is only, I think, maybe now 10 compared to more than 200 on the lateral side. So the difference between the medial and the lateral one is that in your varus knees, your extension and your flexion gap on the medial side is tight in the majority of those knees. So you have to shift your epicondyle not only distally, also posteriorly, which makes it for me a lot more difficult to find the right position. The majority of my varus knees, I don't have maybe that severe deformities like you have, but the most of my varus knees, I'm able to balance with the standard techniques. So the osteotomy, as I said, is only in very rare situations. And I know a paper from Arun Mulaji, I think he's doing it in the varus knees with extra-articular deformities to solve that problem. That's an option. We had 2 days back, we had an extra-articular deformity in a valgus situation. So again, that was definitely an osteotomy on that side. So that can help you with the extra-articular problems.
I think this is more important for a old malunited proximal tibia fracture. Mm-hmm. So those cases usually will need a sliding osteotomy on the medial side. Pradeep, any experience?
Yeah, I mean, the other situation where you can sometimes require this medial osteotomy is when you have a huge lateral opening up in these kind of varus knees, and there's a certain amount of varus instability. So you have a huge varus laxity, and whatever release that you do on the medial side does not compensate for the lateral laxity. And further inflection as well, as Gretchen was saying, sometimes if you release the popliteus by mistake because of the rotation, your jig, you place it wrong, and you do you cut your popliteus, the lateral space again opens up, and then you have a problem with instability. And those kind of situations, because of the laxity on the lateral side, those are the rare situations when you sometimes may need to do a medial condylar osteotomy. It's very rare. I mean, Gretchen has done 10. I've probably done about 2 of them. That's about it.
Just before switching to the next speaker, just one question. In osteoporotic bone, would you like to change your fixation mode, or you will just go ahead with the same screw, or any other ways of fixation you want? Dr. Gretchen.
In normal bone, I don't use any washers. In osteoporotic bone, I use washers just to, for the pressure. So that's the only difference.
Is there any role of any anchors?
Sorry?
Is there any role of anchors? Suture anchors?
No.
No.
Thank you.
I don't have experience with that.
Oh, thank you. Thank you, Dr. Palsar. May I now call upon, yes, Dr. Raja to speak on the soft tissue injury in primary TKA, one of the most dreaded complications, dreaded problem on the table. Yes, Dr. Raja, please.
Are you able to see my screen?
Yes.
Thank you, Dr. C.P. Das, Dr. Tanmay Mohanty, and Debrasiv Pari for the invitation. It's nice meeting you all on this evening. So I'm going to talk about soft tissue injury in total knee replacement. Surgery can be terribly simple if everything goes well, or it can be terribly simply terrible if you land up in complications. So we do land up in complications during total knee replacement. The homogeneous series of 1,795 cases from these authors has shown that 3.8% of the patients had intraop bony complications or ligament complications. To take tendon and ligament complications, it's around 1 to 1.5%. So these are the 3 common structures soft tissue structures, which are most important structures in the knee, which we can have an intra or post-operative injury, medial collateral ligament, patellar tendon, or a quadriceps tendon. So then we'll start with the medial collateral ligament injuries. These are the medial collateral ligament is the most important structure in the knee, and the injury can happen and can lead to knee instability, asymmetric accelerated polywear, and early loosening. So if you look at the anatomy of the superficial medial collateral ligament, it has two parts. It is the second layer of the medial knee structure. It has a superficial part and the deep part. Superficial part has attachment in the middle, just behind the middle epicondyle, and it attached distally at the 5 to 7 centimeter below the joint line, the middle aspect of the tibia. So it has the proximal, mid, and distal portion. The deep portion is the thickening of the medial capsule, which is attached from the middle, just below the superficial medial collateral ligament, and attached distally just below the joint line. It has two parts, the meniscofemoral and the meniscotibial part. So injury can happen at 3 levels. It can get avulsed from the middle condyle of the femur, or at the joint level, which we call as a mid-substance tear, or can from the distal attachment when you're doing a soft tissue release, you can have a complete distal avulsion. The risk factors include morbid obesity, severe varus deformity, patients who have undergone previous surgeries, stiff knee, and considerable medial condylar bone loss. If you do aggressive varus valgus stressing in a patient with severe osteoporosis, you can have a medial condylar avulsion. If you don't identify it, sometimes they go for fibrous union, but they can have a residual laxity, inflection, and extension. Fixing it gives good bony healing and avoids instability. So we need to identify the avulsion and fix it. You can use a hook reduction clamp to reduce the avulsion and fix it with 1 or 2 screws. And usually it heals and there is no residual instability. Coming to the mid-substance transection, it can happen during a tibial cut. When you are doing the tibial cut, you have to protect MCL with a Homan and make sure you don't we do the soft tissue release prior to your tibial cut. The medial capsule up to the posterior 2/3 of the medial tibia has to be released even in a valgus knee. So otherwise we'll have a transection of the MCL. In an obese patient, you need to be very careful. Secondly, it can happen during the posterior femoral condylar resection, where we need to protect the MCL with a Homan. So, or when you try to remove the resected bone or the osteophyte from the posterior aspect of the femoral condyle. In both these situations, you need to protect the MCL very carefully. You identify a mid-substance transection on table, you can do an end-to-end repair with a Krakow type of sutures. It usually heals and gives good results. Sometimes surgeons have augmented it with a mesh graft so that it can give protection to the repair during the healing process. But when there is soft tissue loss, when you encounter soft tissue loss, we always augment with the hamstring tendon. When you feel there is a residual gap after the repair, or the soft tissues are very poor, or the suspicion that the repair might stretch out in the post-operative period, always it's better to augment the repair with the hamstring tendon. This is an example of a patient with bilateral deformity, winsub deformity, right side valgus. Left side is varus, is a very stiff knee. It has a fixed flexion deformity of 20 degrees, further flexion to only 50 degrees, and deformity is not correctable. This is a walking video of the patient. You can see the left knee is totally stiff and then varus with flexion deformity. So we do a varus valgus stress for all our patients with deformity. You can assess how much the deformity is correctable, and the varus is not correctable. If you see, the valgus is almost correctable to acceptable amount of valgus. So we did a tibial cut perpendicular to the tibial mechanical axis, and we tried to do a reduction osteotomy. And if you closely observe, there is a lot of osteophytes behind the medial collateral ligament, and the medial collateral ligament was adherent to these osteophytes. So during clearance of these osteophytes, the MCL was ruptured, and part of the MCL was also removed with the osteophytes. So there was partial loss of MCL, like we could not do a direct repair. So we need to choose the level of constraint, and we need to reconstruct with augmentation. So the knee was opening more in flexion. So we chose to reconstruct the superficial MCL. We used this semi-tendinosis graft fix it to the femoral condyle behind the middle condyle with a bioabsorbable screw. The graft has been fixed to the femoral condyle. We brought it down to the distal attachment of the superficial MCL and we fixed with the suture anchor. So this is how we fixed it. Then we check for stability. So an extension is it's quite stable. Inflection, it's opening. So once we reattach this hamstring graft, the flexion gap becomes stable. But because of the patient having bilateral deformity and elderly patient, we chose to use the one level constraint up. We used the total TC3 type of prosthesis. You can see the distal suture anchor. Approximately, they used the bioscrew. So the right side, the total knee replacement was done. As you know, it's a correctable deformity, and with soft tissue release, it was corrected. And we can see the patient at the follow-up is walking with a very stable knee. There is no instability and has good range of movements. So if there is intra-substance loss of tendon, we always augment with the hamstring graft. This is an example of a patient whom she had a FS type of knee a few years back, and probably she had an intraoperative ligament injury. You can see this medial aspect of the knee where the semitendinosus graft has been harvested and used to reconstruct the MCL. Here the patient, the surgeon has not used the higher constraint implant, and patient landed up with instability. Patient is able to walk on plane surface, but unable to climb stairs or even get into the house to climb 2 or 3 steps. So we had to use a hinge type of implant. Because of chronic insufficiency, we cannot do a direct repair or augmentation. So tibial insertion avulsion, you can see the distal avulsion of the superficial MCL. Sometimes when you are correcting a severe valgus varus deformity and you do an extensive release, you can see distally there's a pus answeriness, and we try to stop the release at that level. If you try to go below that, there is complete avulsion of the superficial MCL. So you can see there is a complete avulsion. You can see the pus answeriness distally, and this is the superficial MCL which is completely avulsed. If there is avulsion, we always try to refix it to the attachment with the suture anchor. So here we're using a fiber wire. And we try to reattach to the distal attachment and protect it from stretching out by allowing partial weight bearing walking and the hinge knee type of brace. To leave it without doing anything, as reported in this paper, they land up in mild laxity. They all heal. They behave like a type 3 ligament injury. They all heal, but they heal with laxity, and the knee could be slightly unstable in flexion. This is a systemic review of all the papers reporting the MCL injury. So most of the time, if the surgeon uses a CR type of implant and does a direct repair, results are good. And some instances, surgeons have used quadriceps autograft, and this series shows that they have used a total of 30 constrained implants, PS7 and 30 are constrained. So they have used one level higher constraint in all this paper from Lee and Lowe. Okay. They have used the one level higher constraint. So in this series, there are 2 outcomes. 4 out of 7 PS knees has to be revised because of instability, and 3 out of 30 constrained implants has to be revised of early aseptic loosening. So there is a worry of using a constrained implant in younger patients. But with the newer mobile bearing type of implants, if you are not confident during surgery, you want to increase one level of constraint, we can use a mobile bearing constraint type of processes. So to conclude, iatrogenic MCL injury can happen when you have a severe deformity and you do aggressive testing. Surgical reapproximation of the mid-substance teres with the Krakow stitch is useful, and has to be augmented with the hamstring in case of doubtful cases, and if necessary, one step higher constraint can be used. In case of chronic insufficiency, the reconstruction methods usually do not work, and we always choose to use a hinge type of processes. Coming to lateral valgus deformity, we discussed just now. We try to use a lateral epicondylar osteotomy to limit the amount of lateral release. In instances where accidentally we release the lateral collateral ligament, and this happens in patients with severe valgus or a previous high tibial osteotomy, we always use one level constraint. We use this figure of 4 tests. where the you can see the laterally the joint opens. When it opens, we need to go for one level constraint higher. So it will prevent future instability. Compared to a varus MCL insufficiency, LCL insufficiency, they do well. That's what we discussed. Even without the sliding, without a fixation of the osteotomy, these patients do well because the knee is always loaded in valgus and the lateral side is always in compression. So we can get away with the semi-constrained type of processes. Coming to the extensor mechanism, we can have an extensor muscle injury or a tendon rupture, or we can have a patellar fracture or a patellar tendon injury or avulsion from the tibial tuberosity. As we know, the blood supply of the patella is from the genicular arteries. A medial parapatellar approach cuts both the medial superior and inferior genicular artery. To combine a lateral retinacular release, which injures your lateral superior genicular artery. Sometimes when you are trying to release the lateral meniscus, you can accidentally injure the inferior lateral genicular artery. So the entire blood supply to the patella can be compromised in case of patients having medial osteotomy, lateral release, and hence the chance of AVN is increased. So this type of patient can have a fracture with AVN. The other causes of patellar fracture includes over resection of the patella during resurfacing, or when there is injury to the quadriceps and patellar tendon during your resurfacing procedure, or your patellar bone, residual bone is less than 12 mm. So these are the causes for patellar fracture. Patellar fractures are usually fixed and protected from till healing. Coming to the patellar tendon rupture, most of them is from the avulsion from the tibial tuberosity, less than 1% incidence. Tubercle insertion is the most common injury. Intrasubstance or inferior avulsion are less common. So it can happen intraoperatively when you are exposing a stiff knee or a patient with patella baja. Postoperatively, it can happen when the patient falls with a hyperflex knee, or can be a traumatic rupture from repeated impingement of patellar tendon on the tibial insert. So intraoperative injuries can be, or early postoperative injuries can be managed by direct repair or refixation with staples and anchors. So if we have a tibial tuberosity avulsion, we can use so in mid-substance tears also can be repaired by direct suture. Instead of using a figure of 8 stainless steel protection, now we use a fiber mesh, which we use to use a figure of 8 type of configuration, so that we can allow early knee mobilization. So this is an example of mid-substance tear which has been repaired, and repair has been protected with a fiber mesh. If it is chronic rupture and poor tissue quality, sometimes we need a augmented technique like hamstring autograft or a Achilles tendon graft, or the entire extensor mechanism allograft. So we can use semitendinosus tendon graft and use it as a loop it around the patella and fix it to the tibial tuberosity. It will compensate for the patellar tendon loss. We can, as we see in this video, they use a semitendinosus, loop it around the patella and the tibial tuberosity, and suture it back. And we also protect it with the mesh, fiber mesh. So the example for a patient with severe rheumatoid arthritis with stiff knee, post-operative X-ray looks good. With the post-op aggressive physiotherapy, patient presented to us after 6 weeks with this picture. Intraoperatively, we could see that the patellar tendon is avulsed from the tibial tuberosity, and there is a gap. We are not able to approximate the tendon to the tibial tuberosity. So we had to do a quadriceps VY sliding down to bring the patellar tendon down. We slide the quadriceps mechanism. We are able to reattach the patellar tendon to the tibial tuberosity and close the VY plasty and suture it and protect it with a fiber mesh. We use a figure of 8 fiber mesh. This is a post-operative X-ray. We could bring down the quadriceps mechanism at least to a certain extent. And now patient has a good range of movements, and there is minimal extensor lag. Some surgeons have advised, this is from Mayo Clinic, they used the diagonal mesh, rolled it and used it as a reconstruction option for loss of a patellar tendon. We don't have experience with this. Coming to quadriceps tendon rupture, the incidence is less than 0.1%. Usually it happens in patients with systemic illness where the collagen disorder and wasting of the quadriceps muscle, or it could be due to excessive resection of the patellar tendon, or after a quadriceps snip or a VOA tendonoplasty. So if it is a good quadriceps, we can bring it down, then we can do a direct repair, which is not the usual case in post total knee arthroplasty. This is a traumatic rupture, we can do a direct repair. But post arthroplasty, the surgical repair usually has limited success. There is a high risk of re-ruptures, 33 to 36% re-rupture. Overall complication ranges from 33 to 100%, including infection. So augmentation is recommended in all these patients with quadriceps rupture. Either you can use a semitendinosus or a gracilis autograft, or a synthetic graft, or a frozen tendo-achilles graft, or a complete extensor mechanism. So now this use of complete extensor mechanism is becoming popular. The entire patellar tendon with the tibial tuberosity with the patella and quadriceps can be used. This is usually fixed over the tibial tuberosity and overlap with the residual quadriceps mechanism and protected for many months. The last option is using a gastrocnemius rotation flap with the tendo-achilles, which can also help to restore the mechanism. It's usually used in tumor resection where we remove the entire distal femur, the proximal tibia where there is tibial tuberosity attachment is totally lost. It can be considered, but the extensor lag is significantly present. Up to 10 to 20 degrees extensor lag is still present. So with that, I conclude on my talk on this soft tissue injuries. Thank you for the opportunity.
Thank you, Dr. Raja. Just I have got one question.
Yes.
How frequently do you encounter this intraoperative patellar tendon avulsion, especially in rheumatoid patients or patients with osteoporosis?
It's very rare. If you follow meticulous surgical technique and protect the tendon throughout your procedure, it's relatively rare. Partial avulsion is very common. That can be sutured back. But avulsion after discharge due to aggressive physiotherapy at home, it can happen. That's the case I showed. Intraoperative ruptures can happen. Mostly it's partial rupture. We always suture it back and protect it. It's not a major disability. Only thing we go slow on post-op physiotherapy.
Okay, thank you. Any other question from the panelists, please?
Yes, Dr. Raja, it's a nice. I have just two questions for you. First thing is, does the bone quality have any relation with the iatrogenic avulsion of the tendons?
Definitely, the patient with the osteoporotic bone, we have a lot of patients with femoral condyle avulsion. Especially, we have a lot of patients with severe varus deformity. When you're trying to balance them, check for stability. Many a times I had femoral condyle avulsion because the poor osteoporotic bone. So if you see osteoporotic bone, you need to be very careful in all your steps. Take meticulous precaution, especially in trying to balance. So do all the steps gently and make sure you don't have avulsion. But luckily, femoral condylar bone knee avulsion is heals with bone-to-bone contact, and results are good. There is no residual instability.
And what is the results about the end-to-end repair of the MCL?
End-to-end repair had very poor results. Initially, when I started practice, where I had an MCL injury, I just repaired it end-to-end. And those patients developed residual laxity. Now I go all the way using a augmentation with or without increase in constraint. So I don't leave it with the end-to-end repair. Though papers support in a patient with the CR type of implant where they have done end-to-end repair, those results has been reported. In a PS type of implant where you have done extensive medial soft tissue release for a varus knee, end-to-end repair alone is not good enough. I think we need to augment with or without a constraint.
Do you believe?
Yes, go ahead, Dr. Patil.
Do you believe, Raja? Do you believe to keep the insertion of the semitendinosus intact and use it as an augment, not by so that we can avoid a anchor stitch on the distal part of the tibia?
I think initially it was described. Now they don't recommend it because it is not in the normal attachment of the MCL. The superficial MCL is attached more distally and in a more lateral plane. Semitendinous is inserted more anteriorly and superiorly. So it is not in the axis of the MCL. So it is not recommended, I feel. We need to attach it to the actual superficial MCL attachment and the medial epicondyle. And if there is an opening in extension, they advise to repair the posterior oblique ligament part also.
So yeah, just another thing, Paddy. See, I'm a CR surgeon, so when we do cut the MCL or accidentally during the surgery, what's recommended is actually, because you normally encounter this when you're dealing with varus knees, and where the lateral side is slightly lax. So one of the things they say is you do the end-to-end repair, but what you need to do is increase the size of your insert. If you're doing a CR knee, you increase your size of your insert. One of the things you should not do is don't convert it to the next level of constraint, that is to a PS knee. If you convert a CR knee to a PS knee with an MCL rupture, it's disaster. The other thing is, for the PS knee, again, you can increase the size of the insert, but invariably, that's only in cases where the avulsion of the MCL is from the tibial side. Like Raja said, what's more important probably is going up to the next level of constraints, that is to TC3. So if you're a PS surgeon, and if you cut the MCL, almost always, you'll have to go to the next level of constraint, that is to TC3. Just trying to increase the thickness of the insert will not work.
So just to extrapolate the effect of MCL repair. So in patients with a small femur and a valgus knee, where you cannot afford to go for a epicondyle or osteotomy, can you think of cutting the MCL and overweighting the MCL? Is there any role? All the faculties, because in small femur, you cannot go for lateral condyle osteotomy. And you have found good results with MCL repair or overweighting of the repair. So can it be extension of that? Dr. Raja, Dr. Graichin, or Dr.
I think that's Krako's this thing where they imbricate the medial MCL. I personally don't have any experience, but the literature does not really support that. They do not really give good results with the. I mean, the Krako in his hands, he had good results.
I think
I'm not sure about everybody else.
Graichin also in his talk has mentioned about this one, which has been used, but he himself doesn't have any experience. That's what Graichin, I believe.
Yeah, that's correct. So I don't have any experience with medial tightening, and my knowledge, the literature is not very convincing on that procedure.
There is a surgeon from once again. There's a surgeon from Kerala who does advancement of the medial epicondyle proximally. Instead of cutting the ligament, he did a medial condyle or osteotomy, and then shifted the medial condylar attachment slightly proximally. That might work. I don't think the ligament imbrication works. It stretches out over a period of time. That should not be attempted, I think.
But as such, you have good results. As such, you have good results with repair of the MCL following your iatrogenic injury. So why the same thing cannot happen when you just do it iatrogenically, knowingly? We have papers supporting MCL.
We cannot say that because the MCL injury is very rare. It's only 1%. In that, people have reported direct repair. That is probably 10 or 15 cases in their series. With that small number, we cannot say that MCL imbrication is going to work. It's a very rare complication, and the results has been due to various factors. You should not overcorrect your varus. If you overcorrect your varus, your repair will stretch out. So Ranawat says always leave it slightly undercorrected. So if you use a slightly thicker insert and try to stretch the repair, again is going to fail. So we cannot use ligament repair as a technique for orthoplasty. The demand on orthoplasty is so much higher than your sports injury. You can work in a different scenario where you have other constraints available, like your cruciate ligament, PCL is intact, LCL is intact, so many other structures intact. So then you're suturing one ligament, it can work. But you're doing a lateral release. If you are using a PS type of processes, then you're again cutting MCL and advancing, it may not work.
Yeah, I think there was another paper. Yeah, there was another paper, I think, by the Delavella, I mean, I forget his name, the group where they looked at these MCL ruptures. And in the PS knees, one of the things that they noted whether you repair it or reconstruct it, probably the more important thing was going up on the level of constraint to the TC3. So between reconstruction and repair, there is still some debate about whether reconstruction is all that useful, but everybody agrees that the key point there is actually going up on the level of constraint. Like you saw the example that even the one that Dr. Raja did, the reconstruction, he went up on the level of constraint to a TC3.
Any local faculties wants to add some points to this discussion on soft tissue injuries, or else you can go to the next presentation.
I think we'll go ahead.
Now I welcome Dr. Graichen for his second presentation on extra-articular deformity. Dr. Graichen, over to you.
Thank you. Just give me a second. Okay, I think that's a very difficult topic. I try to give some guidance and try to reduce the complexity of this topic. So first of all, I think we have to analyze again the deformity, and it can be in all the different planes. The most obvious one definitely is the varus valgus plane, but also on your lateral view, you see sometimes deformities, and what is once in a while hidden in the X-rays are the rotational deformities. So, but in CT scans and or MRIs, you can see also those kind of deformities. Then additional deformities, translation deformity in ML or AP direction, or leg length discrepancies. I will not talk about the last two ones. So if you then try to solve the problem and look into the literature, then I think it confuses you even more. So some of the authors say that almost all the deformities are correctable by TKA, at least deformities on the tibia side of 30 degrees, on the femoral side of 20 degrees. Some others say it's not always correctable by TKA, and then they perform additional osteotomies. You can find literature that perform the TKA and the osteotomy in two settings, or others say that it can be done in a single stage. And then also the sequence, if you do it in a single stage, is again reported differently. Some do first the osteotomy and later on the TKA, and some others start with the TKA and then do the osteotomy as the second step. They normally use the navigation for doing it this way. So if you read a lot, in the end, you're not a lot more wise. I think you're more confused. The same is a bit on the classifications. So again, you see the name Krakow. He had developed one of the classifications, but I think it is more important to make long leg X-rays, AP, and as good as possible also for the lateral view. And then you should have a knowledge about the different values of, for example, your medial proximal tibia angle, your distal lateral femoral angle, and all those other parameters. And I think what also is a very interesting parameter is also, if you look at the lateral view, there is always a flexion of your distal femur compared to the shaft of, in average, 7 degrees. And again, you see the variance of this factor. And we also discussed the slope in some of the earlier talks. So the natural slope is around this 9 degrees. And some individuals have a slope that is more than 10 degrees. So I don't think it's possible to copy that in a total knee. So as I said, you try to identify the problem correctly. So first of all, you measure your mechanical axis deviation. You measure your lateral distal femoral angle, knowing the variance and what is normal and physiologic and what is pathologic. That's the same for the medial proximal tibia angle and for the joint line convergence. So those 4 factors I always measure. And then I analyze the deformity. And I think Paley is the one who's published on that in his textbook very nicely. It's a very thick book, but he covered all the topics on that. So again, you have to measure your medial proximal tibia angle. You also have to measure your angle for the ankle joint, and then you determine the size of the deformity angle here by drawing the chora. So that is the point where the proximal and the distal axis meet at the center of rotation of angulation. That is another, I think, interesting and also very important term that should be known. That is this transverse bisector line. So that means that all those points that are on that line are options to correct the deformity. So osteotomy rule number 1 from Paley is, if an osteotomy passes through this ACA or chora, correction produces pure angulation at the osteotomy site, and the proximal and distal axis lines of the bone becomes collinear, what you see then down here. And you have different ways to do that. If you look at these different points, they are on this transverse line, and you can correct it here or there. So that is then producing an open wedge. If you correct it on that lateral side, you can also correct it in the mid part. Then it's a bit of an opening wedge osteotomy, or you correct it on this concave side, then it's a closing wedge osteotomy. The difference then is, of course, the leg length. So if that leg is longer or shorter, you have the option to correct it. If you want to stay size-wise equal, then you have to do it in that technique. Osteotomy rule number 2 is just showing you if you don't correct the deformity in the chora, but the osteotomy is still located in another plane, then you see your deformity is, the axis is corrected, but the bone ends are displaced. So this is what once in a while is seen on the x-rays later on. You have still a straight axis here, but not a full coverage of your bone. So that means the correction was not done in the correct plane, but still close to that plane. In the osteotomy rule number 3, you're far outside that and you want to correct it, and then you see what happens. Then you have a failure in the translation, and also, of course, the bone ends are not corresponding. And this is what we once in a while do if we try to correct everything within the joint, because then the deformity here is not corrected where the chora is. It is done outside the chora, and that's the same here. And that means, yes, you can correct the overall alignment, but look what happens to the angle from from your ankle joint in this varus knee here. You have then finally a varus of the ankle joint, or in the valgus knee, you have then the valgus in your ankle joint. And the other problem you, of course, often create if you want to correct everything within the joint is that your osteotomies are not parallel. Yeah. And then once in a while, you get into conflict with your ligament structures. So that is definitely something we should think about. Another very important aspect is where's the deformity localized. So it's a big difference if you have a 10 degrees of deformity which is very close to the knee, or if it's far away from the knee. That is the rule of this 10%. So here you see a deformity of 10 degrees, but it's far away from the knee joint, and you see the effect on the knee joint. It's minimal. The closer you get to the joint, the valgus gets a lot more, and by that also your correction, the planes for your cuts are not parallel anymore. Here, in that left situation, they are parallel. In that, they are not. So from a systematic approach, first of all, I think we should measure the amount of deformity and the deviation from the physiological values. And then the second step is analyze how far is it away from the knee joint. And then remember this rule of 10%. And then it's a difference whether it's a femoral or a tibial deformity. The femoral axis deviations, they do lead to asymmetric only of the extension gap, while tibial deviations have an influence on both. And the varus or valgus deformities are also a bit different. So the varus deformities results in valgus resections with the lateral instability, which is a bit different to handle compared to the valgus deformities. They are the other way around. So I think planning is very, very important on that part. Sagittal deformities, they are not that frequent like the coronal deformities. Mainly they are localized on the femoral side. For the femoral tibial kinematics, they are only relevant if they are very close to the joint. And then inflection deformities, you have the possibility of an anterior notching, and in extension deformities, you have the possibility of a posterior notching, like it is shown here on the right slides. And then, as you see here, then definitely you have this this impingement on the posterior femoral condyle. So in a situation like that, I don't think it's very wise to correct everything within the joint. So that should be the normal correction, and the rest is then done extra-articular. So the goal is correct implant position related to the axis and not to the joint. In a biomechanical conflict, correction osteotomy is recommended. So that is the problem of the posterior impingement. That's another example. And this is what we have done, and I think that was not a good solution. We tried to solve everything within the joint, but you see that minimal posterior offset, so that knee is not stable in a flexion. So that would have been the preferred posterior offset. So if the epicondyle is here, then that is the normal amount of posterior offset. That's a specific situation on the tibia. So in that situation, again, planning is very, very important. So you should avoid a reversed slope, but a slope of 3 or 5 degrees in a situation like that can cause a problem here. So in that case, we were lucky. Rotational deformities, not a lot of relevance for your femoral tibial kinematics. a lot of relevance, of course, for your patellofemoral kinematics. Most of the cases you don't have a shaft fracture as the cause. Most of them are idiopathic or are combined pathologies from the hip side, for example, and that. In cases of pre-op anterior symptoms, I would recommend to do this rotational analysis with the 3D CT to have an impression on the rotation of your femur and your tibia related to your patella. And if the rotational pathology matches the symptoms, a derotational osteotomy can be performed. So maybe the reason is not the patella, maybe the reason is the femur. So we always have to analyze that. So here are two cases. That is one with an extra-articular deformity on the tibia side. If you would perform a normal solution correcting everything inside the joint, then you see the difference of the cuts. So on the lateral side, of course, you can reduce that to maybe only 1 or 2 millimeters, but still you have a difference then of around 1 centimeter between your lateral and your medial cut. And such an oblique position of your tibia implant has a high potential to cause problems. To solve everything with a high constraint implant is, I don't think, also a wise thing to do. Then you still have malalignment. That's not the same case, of course. And you still have the high potential of a stress fracture down there, and also, as it's left in varus, of a aseptic loosening early on. So in those cases, we plan to do the osteotomy, and then you can do it in 2 stages, for example, with the nail, or you can do it in 1 stage with the tibia and a stemmed implant, like we have done it there. And to assure the rotational stability, we add another plate. Okay, that's another case. Female patient, you see this post-traumatic deformity on this distal femur. Then she was treated somewhere else. That was the pre-op situation. This is what the surgeon has done. So he tried to correct the distal femur and to correct the deformity, but he was not very successful. There's still this varus deformity left, and he made it even severe because now the insertion of the LCL is damaged, and the patient had an instability on the lateral side. So, and additionally also the range of motion was decreased. So, of course, an arthrodesis can be recommended, but that's a very severe procedure. So then we try to give her some motion back. So that was a correction, everything within the joint, but that needed a lot more of constraint because the LCL was already damaged, and then we had also to correct everything inside. So we had gone for a hinge with short cemented stems. So as a take-home message, I think we have to analyze the deformities in all planes. How much degrees, how close to the joint? Is it the femur, the tibia, maybe both? Is it varus, valgus? What is the relevance for the joint kinematics? If we have analyzed that, then it's a lot of planning. So is my load bearing still within the joint, or is it outside the joint? Is the resection I plan asymmetric, or is it still symmetric? What type of implant I should have on the shelf? Do I need higher constraint? And then depending also, I think, on the patient, age, comorbidities and all that, then we should decide whether we can solve the problem in one setting. Everything may be done by the middle knee, or if you have to perform an extraarticular osteotomy, then maybe it's just the osteotomy first, and then in a second stage, a total knee, or you can do it maybe if it's a healthy patient in one setting. Thank you.
Thank you, Dr. Greichen, for simplifying the most difficult aspect of knee replacement. I just have a couple of questions. Like if I am to put a stem, how much stem should be beyond the osteotomy site? What is the minimum length of the stem that should be beyond the osteotomy site?
I'm not sure whether there is literature on that. So what I normally recommend for my team is at least 2 to 3 centimeters.
Okay.
I don't know about the other.
One more question.
Any comments on that?
I'd probably go even more,
Yeah.
3 to 4.
Yeah.
Okay.
So one more thing is, like many times when you use the navigation for a extraarticular deformity, we found the stem of the implant doesn't parallel to the axis of the tibia. So is there any relation between that, or you can keep any degree of rotation between the axis of the tibia and the axis of the tibial implant? Like if you take away a case of a bowing of tibia and you use a navigation, so we find that the stem of the implant, it doesn't coincide with the axis of the tibia. So what is the relation basically?
So I don't know what, if I got you correctly. So normally you see that problem in your pre-op planning. So if that happens, that is for me a decision to go for an extraarticular osteotomy. Have I answered your question, or maybe I have not understood it correctly?
In my sense, actually it's right. But what I want to say is we have corrected the axis by this process. The HK axis of the limb isn't corrected. But we find in that the axis of the implant doesn't coincide with the axis of the tibia. That is my question.
Okay. Yeah, but then this conflict, you know, if your implant is in conflict with your cortex, then you cannot fix it solidly. So then you have to perform your osteotomy. But as I said, normally you see that problem prior to your surgery, and then you plan for the osteotomy.
So this happens in patients with extraarticular deformities. You have mild deformity and you're doing intraarticular correction. Then your implant will be in line with the mechanical axis, but your tibia will be bowed. And, we have a good cortical contact anteriorly, posteriorly, and laterally. Still, I would put it in a same position so that I have good cortical contact all around, and I don't worry about the axis of the implant.
So how much variation you will accept? The axis variation, how much will be accepted?
Anyway, I'm doing only a minimal intraarticular correction. Probably a 10-degree deformity, I would do an intraarticular correction. If it's more than that, anyway, you cannot correct the deformity intraarticularly. You are going for extraarticular osteotomy. Then automatically it falls into alignment. So that's why you need to use even if you use an implant and you need to use a stem, you use a short cemented stem in this situation, like Greichen is used for the hinge. So we use a short cemented stem so that it doesn't have a conflict with the actual tibial axis.
I think Vishnu, what you are telling, the correction, extraarticular correction or extraarticular impingement of the stem, what you are afraid of. So that you can plan pre-operatively, and if it is actually happening like that, what Dr. Greichen was telling, we can do a osteotomy and correct it and put a longer stem. You can plan it pre-operatively. You cannot do it on table. So if you are thinking that it is going to happen, it may happen, then you have to be prepared for that, for osteotomy, and so that the stem will not be hinging on the tip will not be picking on the one of the cortex.
Yeah, correct. Pre-op planning also is important.
Is there any opinion from other faculties? Dr. Nimal Mahapatra sir is there. Sir, would you like to add something to it? If he's there.
I think.
Hello. Nirmal is not there.
Yes, sir.
Can I ask a question here?
Please, sir. Please, sir. My pleasure, sir.
Pradeep,
Sir, please unmute, sir. Please.
My question is, in case you are deciding that you will do a extra-articular correction, will you suggest that extra-articular correction will be done, then you go for the replacement, or sometimes you can think that I'll do the replacement first and then send for extra-articular correction later? I feel anybody will tell that I'll send the patient for extra-articular correction first by any method of deformity correction, and when the patient comes back to me, I do a replacement. I agree. But as a arthroplasty surgeon, is there a rule that the arthroplasty surgeon does a correction, does a replacement, and leaves the correction for a second stage later? As Dr. Gaichan was telling, that you have an option that you have to do extra-articular correction along with a knee replacement so that you can address both. What is your feeling?
Yeah, so I mean, I would not do the extra-articular correction later. I'll either do it as one stage, which is my preference, very rarely as two stages. If you're doing it as two stages, you could correct the deformity and then do the replacement. But very often you can do it in one stage itself by preoperative planning. And when you're doing that, you sort of find out where the cora is, and I usually do a close-wedged osteotomy. Sometimes you have to do a fibula osteotomy also in some situations. Correct that, and when you put in your trial, you can correct the deformity and put the stem through that osteotomy, and you can place your the tibial tray on the required place, and you can check your alignment at that point in time. If, as Dr. Gratian pointed out, you have, once you put your stem in also, if you have doubts about the rotational stability, there is no harm putting an extra plate.
So this is what I saw Dr. Gaichan was telling, that in case you are planning to do a osteotomy, maybe finally when you do a arthroplasty, the medial and lateral angulation will be too much, where it will be very difficult to balance the ligaments. So will you differ in this idea when the deformity is near the hip, not near the knee? You are doing a knee replacement, but if the patient has got a deformity which is little away from the knee, will you decide that the surgery at the deformed side will be done first, or then you go for this? You understand what I want?
Yeah, no, I do.
Yeah.
And Rajam, you also may want to comment, but basically, yeah, if your osteotomies are going to compromise your ligaments, then I would definitely not do the TKA first. I would do the osteotomy and correct it. I think the key thing is, when you angulate your cuts, it should not compromise the ligaments, and you should not compromise too much of bony resection. If you feel that that's going to happen, it's always better to do your correction proximally, and then on the top or near the hip, and then come and later do your stem. Dhanashekhar, do you have anything else to add, say?
Yeah, deformity closer to the joint, we combine as a single procedure, as we already discussed. You do osteotomy 3 to 4 centimeter away from the joint and do it in single stage. You go to the diaphysis, tibial side is easy to manage. You can do a long stem, and if you add a plate or not add a plate depends on the stability, as Pradeep said. But in the femur, diaphyseal deformity will need an osteotomy and interlocking nailing or something like that. It's better done in 2 stages. I wouldn't do in a single stage. I'll do a femoral osteotomy, nail it, get it to unite, and then come back for a TKA. The tibia, I think up to the diaphysis, we can still go. We have done it in many patients. Coming to the ankle deformity, we always correct the ankle deformity first and then take up the knee replacement. Because when you correct the ankle deformity, the knee ligaments can undergo a lot of stretching, and it can compromise the knee deformity, especially ankle and foot deformities. So this is how we do deformity correction, the extra-articular deformity correction.
So one more question we commonly encounter in this osteotomy is cases of non-union. So Dr. Gratian, do you do something extra to increase or decrease the chance of non-union, or it's just a regular procedure?
Unfortunately, I don't have any specific tips or tricks on that. I think it's a good osteothesis. And as I learned, it's once in a while an additional plate to your stem can solve the problem. But there's no super tip on that.
Okay. Dr. Smarajit Patnaik, if you are there, do something extra to increase your union rates following osteotomy? Dr. Smarajit Patnaik, if you are there. Okay, there is one question to Dr. Graichen from one of the delegates. How much deformity you can correct intra-articularly without an extra-articular deformity, osteotomy?
I think
I read the question once.
Yeah. It's always an individual analysis, and it depends. This angle of deformation depends very much where it is. If it's very close to the joint, then this 10 degrees that has been mentioned is the correct number. If it's a lot far away from the knee joint, then maybe 20 degrees is the border. But you know, measure it and try to plan it. That's, I think, the most important information. Don't go into the OR and then you're definitely, I think, not happy during surgery.
Okay, thank you. Dr. Sunil, I hope you got your answer. Now it's running short of time. We'll go with some case presentation. And the first case presentation, I invite Dr. Ravi Sekar to present his case. Sir, please over to you.
Hey, how do I do that? Sharing the screen? Yeah.
You share your screen.
Yeah. Okay. Yeah. The presentation. Yeah. Yeah. Right. Sorry, I was not sure exactly what my role was. So anyway, I collected these slides and some X-rays. So
make a presentation.
Lady who presented, she was wheelchair bound, 67, obese. She was a couple of years before. Sorry. How do I go back? She was able to have a few steps. Now, for the last 6 months, she was bedbound. She was in her room. She was fed, and she was given a commode close by. So that's the. She was not able to stand without support. So that's the X-rays. X-rays of both knees, AP view. This was taken in 2015, September. That was the lateral view. And that's the post-op X-ray. That's the patient. Because of this meeting, I rang her today, and she is still going great guns and happy. She is able to travel by train on her own. Any questions on that? Can you hear me?
Yeah,
Can you hear me?
yes.
Yeah.
Nice case.
So I was not sure what exactly was going to be my role, so I pulled out these pictures.
I have one question for you.
Yeah.
As I find the post-op X-rays, in the left side you put a stem, and the right side you didn't put a stem.
Yeah.
But what I find is the deformity is more on the right side. So what is the turning point to decide which one you need a stem, which one doesn't need a stem?
Was it more on the right side? No, it's more on the left side.
Okay.
If you look at the left knee, it's grossly subluxated as well.
Okay.
In AP view.
So do you do a full length X-ray in these type of cases?
Sorry?
The patient was.
Sorry, what was that question?
Do you do a full length X-ray for this type of patients when the patient has such a gross deformity?
Oh, of late I started doing. At that time I did not have the facility. I did not know where to get them from.
The right side, you have right side. Why you have not used a stem?
I thought the support for the tibial implant was good enough. If my tibial tray is sitting very well with good bony support all around, without any defect, I need to cover with the tibial tray.
Dr. Pradeep, do you have any opinion on this? Should you go for a extended stem extension on the right side in these type of cases where the deformity is so much, or should we accept?
See, the patient seems to be quite happy with number one.
Yeah.
Second, I think for the left side, he's used the graft and the screws, so that's why he's probably used a stem.
That's right.
And the right side, if he's got good ligamentous balance and adequate bone cover, and if there's no stresses, I mean, looking at the pre-op X-ray, there was significant lateral laxity, but if he's corrected that per-operatively and if the ligament balance is good in both flexion and extension, that's fine. I mean, it all depends on the per-op ligament balancing. If you have a defect like he had on the left side, the stem is there, but otherwise, I'm not sure whether you need that stem.
Pre-op, I was thinking that I might go for the stems on both sides. But when I found that my tibial tray is sitting very nicely on good bone, and there is no worry about any tilting of the tray or collapse of the tray in future, so I did not feel the need for the rod. Whereas on the left side, on the medial side, you see the deformity where I had to use some graft and some screws. There is always worry that it might go into varus by subsidence. So I used the rod.
Can I add something? Ravi, can I add something here?
Yeah, please.
Yeah, please. Just have a look at the X-ray. Do you think a long stem would have been here? I don't think the long stem would have touched the cortex here on the right side if you wanted to put. What I mean to say, you have
might have been impinging on it.
Right. That is what I feel, that whatever you have achieved. See, in India, we get cases where you get such drastically changed joints.
Yeah.
When people from, I think Aichen will agree to it, that in India, the type of cases we get, sometimes we feel it is impossible to get something done. And finally, surgeons try to get in and get it done. So if you see the left side, you can see that it is in the center, the stem. Yeah. On the right side, if you want to put it center, possibly you will be going off center there, maybe the cortex will touch. Yeah. And second thing is, once, as Pradeep told, that you have achieved a very good ligament balancing in this age, and the patient is quite happy. I think we'll be all happy that without a long stem, you could achieve it. So here, if you think of putting a long stem, I think you would have been guided by the stem itself. The angle would have changed completely. Yeah. And the angle what has been achieved here is quite acceptable. I think, Deva, you agree to this, or you want to change it to that?
Yes, sir. He has lateralized nicely, and the balancing has been done correctly. What I was thinking that you could have put a offset stem, but I believe Depew doesn't have a offset stem.
Right.
Depew doesn't have offset.
What is Dr. Kaichan's feeling? Can you just add to something to this?
I think he solved the problem nicely, so I would not have done anything different. So my.
So what we need to remember also, in Bhubaneswar, when we go, we have very, very limited implant selection available. It is interesting. Before I came to Bhubaneswar, most of my cases were CR. When I came to Bhubaneswar and started ask for CR, I was told that CR sets are not available at Depew, by Depew. How? Why is that? I said, he said, everybody does PS here. So then I have had to argue, fought, and requested. Somehow he started arranging. Now most of the implant suppliers have got both options. So offset stems and all those kind of things are not readily available for us. Even for the extension rods, we have to tell them in advance.
We have to be prepared for it. I told you 20 years back when we started in the basic TKR, now the revisions will come to you.
Yeah.
So we have to have everything in hand. can't just think of doing anything that is available. Now we have to do it.
We have to.
Yes,
We
yes,
have to.
yes.
Yeah, nowadays we are coming to a stage
Yes,
where we may have
everything
to
will
do.
be available to you. Things are changing now. The patients have agreed that they will be operated, and majority of these patients will never need revision. We have to have everything with us.
Right.
Vishnu?
Dr. Ravi Shankar, it was a nice case done very nicely. Patients happy, but my concern is looking at the BMI of the patient. So, is there a role of a prophylactic stem? The question is to Dr. Greichen. Would you like to prefer to have some femoral stem looking at the BMI of the patient?
So this patient compared to our patients is still not very heavy. So in the very heavy patients, meaning a BMI of above 40, 45, then I add a stem. But between 30 and 40, I would not add a stem.
Okay.
I think the key here is ligament balancing, and you should not use a stem to substitute for ligament balancing. You need that first.
Yeah, that's right. That's correct.
No, my question is not for ligament balancing. It is for prophylactic fracture, because looking at the BMI of the patient. Because this BMI looks like more than 35 or something like that. So, and the patient is not walking for last 6 months, it's bed bound. And all this supports the quality of the bone. So is there any role? It's just for question from everybody. If anybody wants to put a such type of patient as prophylactic stem in the femur, all the faculties.
There is no point in putting a prophylactic stem for the future fracture. So stem, using a stem is not without any complications. So you should not be using a stem when it is not indicated.
And another thing, as they start walking, the bone quality will gradually improve.
Okay.
As they start walking,
I'll answer that also. If you look at BMI, I use a tibial stem if the BMI is more than 35 in a patient with a small anatomy with a bone defect, because the femoral component is always in compression, but the tibial component is in shear force. So we add a stem to prevent tibial loosening, early tibial loosening, which has been reported in patients with obesity and varus deformity. In the varus deformity with a patient more than 35 BMI, I use a tibial stem alone. There is no need to use a femoral stem because femur is loaded in compression. Second thing, when you lateralize the tibial tray, the bone defect is reduced. So we may not need a stem in many of your varus knees. Third thing, you need to add a stem if you add a constraint. So from a PS, you go to a TC3 type of implant, then you need to add a stem. Other than that, there is no other indication, and this patient probably doesn't require a tibial stem on the right side because it's nicely lateralized. The residual defect after you lateralize is smaller, probably.
yeah, no problem.
Is there any faculty wants to add something to this presentation, or should we go with the next presentation?
We'll go with the next presentation.
I would like to show another couple of pictures. For the next time, I will pull up his X-rays.
Okay.
This is a patient I operated about 4 years ago. I haven't got his X-rays, but I will show you the X-rays next time. So he's got a windswept deformity, varus and valgus.
Okay, sir. We'll
Yeah.
again.
I'll get the X-rays next time.
Tell us what implant you use, sir.
So same DePuy.
CR or PS?
PS with tibial rod.
On the tibial side, you would have had a contained defect.
I have used just a PS. Probably I should have, but I didn't. I'll get the X-rays next time.
Presentation, and
Sorry?
with that we thank you,
Yeah, go
Dr.
on.
Ravi Shankar, for this presentation.
Thank you.
And we now go with the next presentation, and I welcome Dr. Satish Rai to present his case.
Thank you.
Dr. Ravi Shankar, you need to unshare, then only
Okay.
Dr.
Okay, I do that. Is that done? Yeah. Is that done now?
Yes,
Yeah,
done.
looks like.
Right. Thank you.
Dr. Satyajit, please share.
Yeah, sure.
Okay. ये what ये किसको क्या करूं?
This one. So, can all of you hear me?
Just go to the presentation mode, please.
Yeah.
Yeah, thank you.
Okay, this is the case of a 55-year-old male who is a daily laborer by profession, and he had a complaint of a pain initially over the left knee for the last 12 months and had a difficulty in doing the day-to-day activities. Later on, for the last 8 months, there was a complaint of a limping and a giving way of the left knee, and he was utilizing a cane for his daily activities. The patient had no comorbidities. So on examination, we found that there was a flexion deformity of about 10 degree with active flexion of up to 70 degree and further passive flexion of up to 80 degrees. There was associated varus deformity of 25 degree with gross laxity. And the patient was walking with a varus thrust to the knee. The rest of the joints, bilateral hip and contralateral knee, were normal. So these are the X-rays, which you find that the left knee there is a gross varus deformity and subluxed knee, and there is a medial defect in the tibia, as well as a large osteophyte over the suprapatellar region. This is the standing X-ray showing the varus deformity, and a short video of the peroperative showing the gross laxity because of the gross medial defect. And upon the peroperative, we found that there was around 1.5 to 1.7 cm of around the medial defect, measuring the medial defect. So the decision to do was to go for a PS knee, and for the medial defect after the tibial cut, we did screw augmentation with cement and the tibial blade split. The follow-up, which shows after 1 year, and this is the follow-up, and this is the flexion of the knee operated and extension, and a short video of the present walking status of the patient. So this is the case which he did, and now the patient is walking with a slight limp on the left side. So that is my case presentation.
Thank you, Dr. Satyajit.
Yes.
It's nice. The outcome is gratifying. Now I'd like to ask Dr. Raja, is there any particular trick for soft tissue release for patients having posteromedial subluxation? Any particular tricks you like to have? Hello. Dr. Smarjit Patnaik, can you please
Yeah, if you want to have a posteromedial soft tissue release, the most important thing where we have to understand here is the initial part of exposure of the medial part of the knee. Should not be considered as a release. It's just a part of the exposure. And by the time you finish this exposure, always get your stress tests, the Valgus stress, and see how much of knee is getting corrected. Because that's a very important criteria following which you can try to go ahead with the amount of bone resections or your ligamentous balancing you want to do. Now, when you come to your posterior medial soft tissue release, it's very important for you to go right posteriorly, because most of the tight structures are present mostly posteriorly, even up to the posterior cruciate ligament. So because I normally do always a PS knee, so for me the posterior medial release is exclusive, is entirely right up to the PCL. So once we release all those structures, then we come back and see how much we have able to correctable, we are able to get it. And it's only after that, then we go for the medial collateral ligament pie crusting or the release of that the medial collateral ligament structures.
Thank you, Dr. Smaraji. Dr. Satyajit, like to ask you, during this procedure, what are the most difficult steps you encounter to complete the surgery?
The most difficult one would be to the release, as Dr. Smaraji has told, to the ligamenting balancing, because after the soft tissue release, because it was not much posterior, the ligamentous release, the medial soft tissue release was not entirely done much more posterior. It was up to the posterior medial corner. And after getting the cut, we could find that it was very difficult, but there was a lateral laxity still persisting. So for that, we had to do a little bit more of an exposure, and then we could find a way to get the insert in and get a ligamentous laxity balanced. So the most difficult part was to get a soft tissue release and then look for because it was an osteoporotic bone, little bit osteoporotic, we had to find there was the avulsion from the tibial tuberosity was not there, because soft tissue management during the per-operative period is too difficult for us till now.
Satyajit, can I ask you something?
Sir.
See, you have done a beautiful surgery. I am very happy about it. Now you told one thing that my patient is limping a little.
Sir.
Did you try to know why the patient is limping? Is it that by physiotherapy will improve or something?
The thing is that we are not happy with the flexion which you have achieved on table, and now the flexion which is now after a period of 1 year, the flexion moment has decreased. The flexion has decreased.
How much?
Around 20 degree. Around 20 degree of flexion. But on table it was around 90, but now it has come around to 70 degree.
No,
so
I don't agree with you. Why I am telling you, see, 70 degrees of free flexion, I don't think your patient will limp. That is what I am thinking. If your measurements, everything has come, if the limb length is good, why the patient will limp? 70 degree of flexion, free flexion in a knee, I don't think your patient will limp. Something else is there, what we have to find out. Otherwise, maybe by only exercise, maybe by physiotherapy, this patient will come back. Let us just ask other people, because see, you have operated and I have seen a beautiful result. Even I have never done a case like that, giving such a good result. So let us ask Pradeep, what is your feeling? They were trying to just ask, in case we get something out of it, should we see the X-ray once more, post-operative X-ray, or when we think about the muscle power, other thing, the cause of this limping can be anything. But I think majority of these patients, sometimes they need a little physiotherapy, and sometimes the feeling itself. I have found a lot of patients limp, and after 1 month of just psychotherapy, they come out with the limping. What is your feeling, Pradeep, about this? Do you need to see the X-ray? If you want, you can have a look.
No, I mean, of course, X-rays definitely will tell us a lot. You know, I mean, especially if there's lateral laxity. But in this particular case, a lot of the deformities seem to be correcting. It almost comes to neutral, which means that the varus instability is probably because of the large defect itself. And when you take off the osteophytes, something like most of it would be corrected. The other thing is when you put when you put a graft, it's always better to put a stem, because again, there can be chances of tilting and failure of the graft. So that can again contribute towards a tilt. And of course, if it's a long-standing deformity, there can be changes even in the pelvic muscles. So what Dr. Tanmay, I think, was mentioning was about the physiotherapy, also focusing on the hip and other thing. I think that's what you were referring to, sir.
Was there any pathology in the hip?
No, there was no pathology. On the same side, the hip and the contralateral hip and the knee were all normal.
So how long is the follow-up, sir?
It's a 1 year. It is just a year, 11 months to be exact.
But have you put a graft or it is only screw and cement?
It is only a screw augmentation with cement,
All
not
right.
a graft.
Okay.
Okay. Then it is fine.
Yeah.
Can I just add one point regarding this limping? It's a very good habit to teach your patients by your physiotherapist that you walk on a single line.
Okay.
The moment your patient learns to walk on a single line, they tend to develop their abductors of the hip and they don't limp that much. The drop and the thrust which is having, the Trendelenburg thrust, that will much reduce once you ask your patients to walk on a straight line. So as in this case, you have lost some amount of flexion, the patient is still limping. If it is a painless limping and you are losing flexion, probably we should be more focused on the post-op rehabilitation of these patients. I think intraoperative pretty decent job has been done. The other aspect of medial side release is before you come to the collaterals, the femoral side of the capsule and the posterior medial structures also have to be released where you get better balancing, especially in this case, when after you got all your releases, the lateral side was some amount of laxity. So that itself shows that probably the knee has not been balanced perfectly.
Pradeep, how frequently you do a pie crusting? And if at all you do, where do you do it? Near the femur?
Yeah, I mean, I've almost never done it. It's even with deformities like this, I think it is possible to do. I mean, the steps that you
this
probably.
deformity is actually correcting actually. It's
No, even otherwise, you do remove the osteophytes, you release your posteromedial structures, the osteophytes as posterior capsule, then you do lateral shift and medial resection, reduce the size of the tibia if needed. And with doing this, I would say, about 98% to 99%, you'll be able to correct most of the deformities. If at all you do the MCL, I've done a few just for the sake of doing it, just to see what it's like. If one of the dangers is that please do not do the deep MCL. If at all you're doing it, you do it only with the superficial MCL. One of the, like everybody says, pie crusting of the MCL. It is only of the superficial MCL, if at all, that you want to do.
So what is the good site to do it?
Yeah, I think Dana has probably done a few more of these pie crusting. Dana, you want to take that question?
Yeah, I did a few pie crustings. So I do a general balancing as what Pradeep has described, and in spite of releasing the superficial MCL, right, 5 to 6 centimeter right from the joint line, and there is a further risk of complete MCL release. That is the stage I do that, and that is recorded very, very rarely. And if at all I do, I use a needle. I use multiple punctures, only the superficial MCL. And initially when I started, I did it in the joint level, and I had problem with MCL rupture. So I do it only the superficial MCL distally, and only there is a risk of complete MCL avulsion. That is the only time I do it. I don't do it as a routine. And always there's a risk of MCL rupture or complete avulsion.
Gaichin, any experience on this pie crusting of MCL?
No, I don't have a lot of experience with that. My deformities are not that bad.
That's why you're keeping silent.
I found that this, the lateral shifting and resection medially and undersizing of the tibia, with that, you're actually able to avoid the pie crusting quite a bit.
Sometimes what happens in a fixed deformity, when we go ahead and put the trial implants and all, we find it's a minimal amount of tightness on the medial side, even after you have released everything. When you are trialing it, you find little bit of tightness on the medial side. So that point, if you do a little amount of pie crusting, I believe that helps. And that is what I believe. But I think Raja.
Excessive medial tightness and that can be reduced by minimal.
Because you have thought that everything has become fine, you trial it, but even then, after trialing, you see that little bit of tightness is there.
Sometimes it happens after the cementing. You do a balancing trial process, everything is fine. Once you do the cementing, the posteromedial defect is reconstructed and one or two additional cement. Then you see it is very tight, then we can do a pie crusting. We do not achieve any major deformity correction with the pie crusting. We just balance the medial tissues. That's all.
It's a question to Dr. Gaichin. See, if is there anything special when you do a posterior capsule release? It is a question from the delegate.
No, I think it was nicely described by the former colleagues. So it's all the way around, and then going down on the tibia and out on the femoral side. Take out the osteophyte. That's the key, and yeah, oh, that's it.
Okay, thank you all. So before going to the last presentation, there is just a regards to Dr. Graichen from one of his fellow, Dr. Sunil Das, who worked under you and he has conveyed his regards to you.
Thank you very much.
Thank you.
Now it is, I'll just mention here, it is Dr. Sunil Das who contacted Dr. Graichen, and finally he agreed for being part of this program.
Oh, so nice of Dr. Sunil Das. Now I request the last presentation of the today, Dr. Saurav Nanda, to present his case. And Dr. Saurav Nanda, it is over to you.
Hello, sir. Am I audible?
Yes. Yeah, you're audible. Please go ahead.
Yes, thank you for the opportunity. Good evening, everyone. So I had a 62 years female patient with complaining with bilateral knee pain since last 6 years and varus deformity along with right proximal tibia deformity. She required assistance for standing and walking, affecting her activity of daily living. She was hypertensive and under medication. So a varus deformity of 30 degree was present in the right side and 20 degree was on the left side. She had a 20 degree of fixed flexion deformity on both the sides. So this was the X-ray with grade 4 osteoarthritis in both the knee with stress fracture in the right side. So this was her full length lower limb X-ray showing the deformity in detail. On valgus stress test, deformity were somehow correctable in the left side and the right side. So, and this is how she is walking. So initially the patient was advised for bilateral TKR because of financial constraint, unilateral total knee was planned. So the left side TKR was done in the fast go. Intraoperatively, there was a complications. There was a medial bone gap of size of 0.5 centimeter, which is planned to fill with screw and cement. But while applying the screw, there was a crack. There was a crack along the screw line. So initially, a screw was planned to put in this area, but there was a vertical split, incomplete vertical split, and this screw was put to hold to the fragment in the place, and so that we can get some amount of compression. And the right side, the stress fracture side was managed with intramedullary nailing with fibular osteotomy here. So this case is open for discussion. If anything extra we can able to do for that patient.
Okay, Dr. Saurav, as usual, my first question will be, what will be your learning points for me to learn from this particular case? Where I should be careful while dealing this case?
Yes, sir. The patient was osteoporotic while putting the screws to fill the medial gap. Some amount of cautiousness should be there, and I need to that erase adequate amount of medial soft tissue for getting the correction to correct the deformity. So these two things, okay. I think it is a learning point for me.
Okay, thank you. Dr. Pradeep, would you like to do some different way, or you are satisfied with this present?
I would definitely do, one at a time. I wouldn't do both together at the same time because they're very complex knees. I may have done the right side first and then the left side. The right side, if you can just show us the X-rays again, Saurav.
Yes, sir.
The pre-op X-rays. I probably would have done that at one stage. You have another X-ray. Yeah, that should be fine. So I probably would have done it at one stage. And he said it was osteoporotic. For the alignment, for the tibial alignment, I would use the intramedullary alignment jig, not the extramedullary alignment jig. I put a stem which is going through the fracture site. The ones that I've done with this, where it's been osteoporotic, I've actually used a sleeve for derotation of the proximal bit, because there are some where I've actually done it without the sleeve, and I found that rotation was an issue. So for derotation, sometimes I've used a sleeve in the proximal bit, especially when there's a big defect on the medial side. In this particular case, actually, you can see in the post-op X-ray after the nail has been put, there is quite a big defect on the medial side. So in some situations, you may have to use the sleeve. But otherwise, I would do everything at one stage. You can show the post-op X-rays where you put the nail in. Yeah, the one with the nail. The one with the nail. Yeah. So here you can see there is a huge medial defect. Again, for the defect and for the rotational stability, I may sometimes use a sleeve. But otherwise, if I don't need it, I'll just use at one stage, I'd use one with a long stem. A plate if necessary for derotation.
Okay, Dr. Pradeep, as you said, you will go with the right side. I have encountered some problem dealing with the endosteal callus. So how do you manage? Actually, many times I face with the undersized stem. I cannot overcounter the endosteal callus. So any tips for that?
Yeah, I mean, if necessary, you can do a small, make a small opening at that particular site and go through and ream it through. I have taken peroperative X-rays on some occasions when I've had a problem.
What I would have done is I usually open the fracture site if it is unstable. If there is a non-union, I usually open the fracture site and then curate it thoroughly and open the curate and nibble the fracture ends. Put a small plate to temporarily stabilize the fracture, and use a extramedullary jig and use a Windsor technique. Use the lateral tibial plateau on the medial defect to reconstruct the tibial defect, and use a downsize the tibial tray and use a long stem. And if it is stable enough, I won't put a plate and allow immediate weight bearing walking. If rotationally is unstable, which we expect in this particular case because of severe osteoporosis and thin cortex, I will add an additional plate for the tibia as well. So I would have done the right side and I would have done it in one go, probably a different, slightly different technique. I'll pack the fracture site with the cancellous graft from the TKA cuts. That would have been my approach.
Raja, it is a question from my side. It is a repeat question. You can take it. The length of the stem, what you would have preferred? You are telling that you will put a plate and possibly it is unique on the upper part, it will be only one cortex. And the lower part, you would have been giving both cortex. Yes or no? About the plate. Or just temporarily put it so that the stem goes in the right direction?
Usually I put a small plate temporarily. Usually it's in the anterior cortex, close to the anterior cortex.
Okay.
But most of the time when you're reaming the stem, the screws are impinging on the reamer. You want to get a good diaphyseal fixation. Usually it is the upper mid-third junction where the isthmus is. So that is the place you want to get your stem fixation. We're trying to ream that area and get a fixation there. The screws impinge on the reamers. So that stage, I generally, once the tibial cuts are done, I remove those screws and then ream the diaphysis and get a fixation. Usually it is around 115 to 150. If it's I use a straight stem. If there is a bowing and there is a eccentrically going stem, I use an offset stem so that my tibial component position is not affected. Usually it's 115 to 150. We get a fixation in the isthmus, which is in the upper mid-third junction.
How much it will go to the opposite side of the fracture? How much? Because Dr. Gaichan told 1 or 2 centimeters will be enough. Pradeep told that it is at least 2 to 3 centimeters. What is your opinion?
As much as it can.
If it is, we go up to the isthmus, you just cross the isthmus. So once you cross the isthmus, there is good stability. So that is the level I will come down. Probably 3 to 4 centimeters down the fracture site, probably you'll get a, if you see the lateral view, you can see the narrowest part at the middle of the tibia. In this case, there is a slight anterior bowing.
And what about the plate, the extent of the plate? Will it go more than the length of the nail, or it will be just maintaining the rotation?
It's only for maintaining the rotation. It will span only the fracture site to get 2 or 3 screws on the either side.
Thank you.
Dr. Graichin, what will be your approach to this patient? Can you please unmute yourself? Dr. Graichin, please unmute yourself. Yeah.
So I think exactly the same. I would have gone for the right side. Would have done it in one procedure with the long stem, bypassing it. I would not have used the 150. I think 115 is long enough. If you look at the lateral view, it's not an exactly lateral view, but there's a lot of slope on that tibia. So maybe I would have gone for a sleeve, leaving it on the medial and posterior side a bit in the air, and an additional stem. Then I can possibly avoid an additional plate. But if not, then I do not hesitate to add an additional plate just for rotation.
Is there any different opinion from any other faculties, local faculties, Dr. Pradeep or anybody else would like to add something? Dr. Ratan Mohanty would like to do it differently, or?
No, I think what Mr. Gaisen has told, that's all right. We have used a long stem and with a, if required, a derotation plate.
Okay. So I think the Dr. Saurav has done a very nice job, and really he just completed his residency just a couple of months back and done a very nice case. Thank you, Dr. Saurav, and doing this a good case. And now I over to Dr. Devarapadi for the further continuation of the discussion.
Yeah, thank you, Dr. Ratan Mohanty and Dr. Vishnu Prasad Patra for moderating it. We have overshooted almost half an hour, but it was a nice discussion. I thank Dr. Pradeep Punus and Dr. Dhanasekar Raja. They had been, Dr. Pradeep had also come for the previous presentations of the previous webinar. We had 3 of these webinars, all within a period of 1.5 hours. Because of this pandemic, we had to go for a virtual webinars as well. Our annual conference was cancelled. And I, last but not the least, I thank Dr. Hiko Graichin for accepting the invitation to be a part of this. And we learn a lot from you, and this difficult extra-articular deformity correction and the epicondylar osteotomies. I think those will help many of the budding surgeons for treating difficult varus or valgus deformity cases in case of total knee replacement. At the end, I will thank my executive committee members, my president, Dr. Tanmay Mohanty, and also president of Odisha Orthopedic Association, Dr. C.P. Das, and secretary of Odisha Orthopedic Association, Dr. Biswajit Sahu, for giving the support for these webinars. All the webinars have been done under the aegis of the Odisha Orthopedic Association. Hope we do future webinars, and I will invite, we will try to invite other faculties also, so that it will be a good learning points for all the webinars. And this webinar and all the 2 other webinars also had a pan-India representation, because we have contacted all IOA members, IAA members to be part of this, and it has good attendance. So I think we'll join in future. Thank you, Hiko, for being part of this, and thank you for giving such a nice lectures and such a long time of attendance at this webinar out of your busy schedule. Thank you, Raja, and thank you, Pradeep. I think we'll end this. We'll end the live session, and hope we'll join back soon. Thank you, everyone.
Okay, thank you.
Thank you.
Thank you.